right. All right, presenters, there's money in this. You do it right. Great question, and I wanted to lead with this one. To any of the presenters, someone was very curious to know what led you into the focus or special interest in your research of ketamine. What sparked your interest or your passion for the work that you're doing now? Francois,
I can start it off. I'm probably the most unlikely candidate to be in this field, being an ex-ostrich farmer, in South Africa. But I've been very interested in just sort of shifting paradigms in chronic pain work. I've been researching all sorts of different ways, like, ultrasound-guided ways to sort of help with pain, but it just never got to the core problem. And oftentimes it's the existential pain or it's central sensitization. And I've seen some research over the years come out about ketamine, and I've been using ketamine, not myself, of course, in the ER, but for about 25 years. And I've seen how rapidly ketamine works for A, pain, and B, for suicidality. And it just drew me into this field. And I thought, this is going to be huge. This is going to change psychiatry, mental health, and I think it'd be, it's going to help our patients. That's how I got involved.
Lovely. Excellent answer, by the way. Anybody else want to share quickly?
I first encountered it in doing training as a psychedelic psychotherapist. One of the things they want to do is provide an experience. So that was my first encounter with ketamine. And I had heard that it was sort of like, okay, this is a stand-in until we can get the real psychedelics. And that was not my experience of it. And I became very curious about this rapid-acting psychedelic, not psychedelic. It has features of psychedelic, but it really stands on its own. And I don't think it should be considered a second-rate psychedelic or something that's less than. I think it can provide, and Phil Wolfson's perspective on it, which he really ties in with his Buddhist practice, the experience of no mind and of being free of ego, I think is more pronounced in ketamine than in the other psychedelics. It doesn't have the same kind of pathos, the same kind of biography, but it is really an experience of being free of ego that is it's worth it.
I assume this is from physicians that might be referring patients. I'm curious to know, what is the ideal patient profile for ketamine treatment? Are there inclusion-exclusion criteria to be mindful of? Michael, do you want to take that? Yeah.
One. So I think what we've learned, and correct me, Zach, if this is wrong, but I remember this from one of the analyses that I read, and yours was probably the best, but I don't know if this was from yours, was long-term chronic stress seems to have best results. And if I was going to say that would be the ideal. What they discovered in that particular look at it was that shorter term, more situational sort of seeming situations didn't respond as consistently. Does that sound about right?
Oh, okay. Makes sense to me.
And then so for us, inclusion-exclusion criteria, I'll start with the exclusion. We have a pretty narrow exclusion criteria, which just sort of means who we don't treat right now. And so if you have these sort of situations, we wouldn't be treating you right now. And there's more exclusion criteria coming from Anita, so I'll let her take those. But from my assessment, it's if you're acutely psychotic, that would be an absolute exclusion. So if you have psychosis right now, in this moment, it's not part of wellness. It's definitely needs treatment of its own. You would be not a candidate. Beyond that, it's really about stability. And so if you have an acutely unstable social situation in your life, if you have an acutely unstable sort of behavior pattern, so if you have a sort of a disorder of, say, a personality or something which is very chaotic right now, that would, in other words, you need other things first, really, before you get this kind of therapy. So those are the absolute exclusions right now. As far as my mental health, do you have some from your land?
Well, we went through the medical contraindications to treatment with ketamine. There aren't that many, and most patients actually would qualify for ketamine treatment because there's not that many patients who have those severe contraindications that would actually be seeking a treatment like this. I think ultimately, depression or major depressive disorder coexists with many other disorders, and so we have to be cognizant of that fact. And a lot of our exclusion criteria is not necessarily absolute. So we do analyze them on a case-by-case basis. I am in constant discussion with Michael whenever a patient is referred to us so that we both evaluate those patients separately and ensure that we're actually choosing the appropriate people for treatment.
So I'm going to say with inclusion, so inclusion means who we're taking right now. And so so what we're including in our catchment is treatment-resistant depression at this point in time. And so that means a depression that is basically not responded to a number of treatments, basically 2 trials of an SSRI or psychotherapy. So that's a pretty narrow, that's a pretty wide open inclusion criteria. So, depression is a pretty common mental health condition. It often coexists with a lot of other conditions. For example, PTSD or OCD or substance use and so on. So as long as you have depression as part of the profile, what we're not treating right now is exclusively things like we don't have a program really that's suited for exclusively addiction. So if addiction is your primary problem, our program is just really not yet robust and kind of comprehensive enough to manage that. Also, if you have if you're coming to us specifically for an eating disorder or specifically for, sort of antisocial pattern of behavior or that kind of thing, that's not coming into our inclusion criteria. If you have those things in addition, if you have eating disorder issues or substance use issues or some conduct problems in addition to depression, that's not an exclusion. But if you don't have depression, and that's your primary problem, then our program's not really designed for that. So does that make sense to everybody?
Actually, a bit of a follow-up question then. Will treatment be offered to patients with CPTSD?
With which?
I assume it's chronic PTSD?
Yeah, chronic PTSD. So that would be, it almost always goes together with some depression. So absolutely, yeah. Chronic PTSD would also be one of those that we would be looking at with our program.
All right. Also on the referring side, what risks or ethical responsibilities for referring physicians, what are they, who have patients wanting ketamine-assisted therapy? Francois, maybe that's one for you.
Yeah, I think it's a good question. I've heard it before. What are your, what's the college going to say about your referral to a clinic? And I think the important thing to know is that the referring physician basically will refer the patient to a whole group of specialists. So that referring physician does not take the responsibility. I mean, it's just a referral like any others. The patient will then go through a whole process to ensure that they're a good candidate, a good fit for this program. So I think that really reduces the liability, I guess, of the referring physician. Yeah.
Great. Anyone else? Comments?
I think when we talk about the responsibilities and the really understandable reluctance of physicians to try something that's new and that has been so stigmatized, and I think ketamine is right on the border, but you'll often hear people, oh, isn't that a party drug or what have you? But I think that as we're trying something new and we see these tremendous results in the short term, we need to be brave and courageous and try to think outside of what we know and I think what we've recognized increasingly over the past 5 years is that the war on drugs is just wrong, and that a lot of the stigma that came with it and a lot of the prejudices that came with it are based in unacceptable prejudice. They're based in racism and they're based in wrong-headedness. And so, unfortunately, when we talk about these new drugs that, or not so new drugs that have been tarnished with that reputation, it's not legitimate.
I think there's even another part to that, I understand that everyone as physicians are burnt out, they're tired. It's hard to learn something new or be interested in something new that you haven't heard about before, take the time to be educated and understand, that there is actually evidence. I think the preconceived notion is that there's not very much evidence, it doesn't last very long, there's not great support for ketamine, but Zach obviously pointed out that the evidence actually is quite robust. It's mostly about educating people so that they can make informed decisions for their patients, but I think that's a hard bridge to cross at this point, because I do understand that people are tired and burnt out and frustrated.
Anita, this is probably a good one for you too. Someone's curious about what's the difference between ketamine being administered in a hospital versus a clinical setting?
So multiple differences. One, obviously, in a hospital setting, we're usually using higher doses because our intention is something completely different. So we're aiming for complete anesthesia or analgesia from a painful procedure. Oh, see, my mic. So that is one of the differences. The other difference is we talked a little bit about set and setting. So when we're doing ketamine for treatment-resistant depression in an outpatient clinical setting, the goal is obviously to make the patient feel comfortable. It's to invite them to experience something that is dissociative in a safe environment where they feel supported. You know, I work in a hospital, I administer ketamine all the time. The environment is completely different. There's bright lights, the patient is often in pain or uncomfortable. There's no psychosocial support for whatever they're going through. There's people potentially holding them down, et cetera, et cetera. That is a completely different scenario. They're often experiencing something painful and uncomfortable, which is why they're getting ketamine in the first place. So having ketamine in a different setting, I mean, our patients come into our clinic, they are greeted by warm, friendly people, they're taken to a very comfortable room, they wear an eye mask, they have headphones on, they listen to comforting music, they're administered their dose with people who are there to support them and facilitate them. It's a very quiet, peaceful process. It's completely different from what happens in a hospital setting.
And I would add that they've met those people before. So
yeah,
they've been introduced to them on a previous day, they know them, and they've shared with them, and they've been prepared exactly what to do if they're feeling uncomfortable or if they're feeling a bit panicky. They kind of rehearse that in advance on a day
not in
before.
Yeah.
So they're coming in there with a lot of knowledge.
Michael, this would be a good one for you too. There's reports of people having poor experiences or bad trips on psychedelics, even psychedelic-assisted therapy. What are the risks of that when using ketamine?
Great question. Right, we had talked about that question in the break. So, bad experiences, in a way, what we're trying to do when we're doing the preparation work for people when they come into the ketamine experience is to let them know in advance that they might have some experiences show up that aren't going to be wonderful because, in a way, part of depression is trying to avoid unpleasant memories, unpleasant facts of life, unpleasant situations, and because we don't have the energy and we're so depressed, we just want to not think about that stuff. And it very often will show up. So even, with MDMA therapy, and MDMA, they call that ecstasy, right? And in those studies, people are like, why do they call this ecstasy? Because I'm experiencing things that are quite unpleasant here. But you're experiencing them because this part of getting better, and you're with people who are right there with you, you're not alone, and you also have the medicine support. And it's not like, so when that all happens together, it's therapeutic. And so the entire experience, even if it was unpleasant, at the end of the day, people will say that was the most important experience of my life. So I don't know that it's fair to call that a bad trip. I think a bad trip is where basically it was the wrong place, it was the wrong time, nobody prepared you for it, you thought you were going to be having fun when you took this thing, and you ended up having a nightmare, right? That's a bad trip. But that wasn't a clinical setting, and nobody prepared you for anything. In fact, why it was a bad trip is that you weren't prepared. You didn't really understand this medicine you just took, right? So.
In your friend's basement.
Yeah. With a bunch of people you didn't really know. Yeah.
All right, and this question is...
Oh, sorry, if I can add to that. I think, one phrase that sticks with me from psychedelic psychotherapy is that, where there's dragons, there's usually treasure. And, as part of depression, so much of it is avoiding, worrying that you're going to have a bad trip with or without psychedelics, but there's a bad trip around the corner, whether it's a psychedelic or not. And so you shut down entirely, whether you're afraid of re-experiencing something terrible or just that it's going to happen. So with psychedelics, if you have that, or ketamine, if you have that experience, there it is. There's your bad trip, and now it's over. And now you're back. And so you've learned you can have that.
Wasn't it, I don't remember which one of the psychedelic guys it was, but it's like, when you see the anaconda, you go in and through the anaconda. I thought that was hilarious. In and through. Okay.
All right, this question is actually addressed to you too, Michael, and I assume it's in reference to your presentation. The person wants to know, how would you describe a spiritual experience?
Oh, goodness. Okay, well, I think that goes along with what's transpersonal really mean, okay, because I talked about transpersonal psychology. And I think what it really is an experience that takes you outside of yourself, okay, because most of our lives in the Western world, everything's about self-esteem, self-this, self-that. What do you want to do when you grow up? Everything's referring back to yourself. And so we've kind of lost this idea of what even is spiritual anymore. But when you have an experience where you kind of exit the picture and you're connected to something much greater than just you, I would say that's kind of what a spiritual experience boils down to. And thoughts on that one?
No, I like that. That's great.
All right, well, we do have time for a few more. Any questions off the floor? Go ahead and just raise your hand.
Question.
Yes, please.
Just to preface, we have a deluge of suicidal patients, chronic overcapacity, and fairly poor predictive values for people actually completing suicide when they present at the ER. So some of them get sent, fingers crossed, others need to get admitted. And with this evidence you've presented, it seems pretty logical that that could be a great fix in that acute setting. Are you guys aware of any health districts or hospitals that actually do that routinely?
So, not routinely, but there is programs in Calgary actually where they are admitting acutely suicidal patients and then running intravenous ketamine infusions as ordered by the psychiatrist and run by anesthesia. So that does exist currently. It's not widespread for sure, but I think you bring up a really good point that there is so much potential for this, particularly in places like the emergency department. I mean, if we can reduce having to admit someone and know that they are very likely going to be safe, I think that is a huge thing that the government, et cetera, should get behind. But as you know, things move slowly.
I believe it's been done in Kamloops as well,
Yeah.
Dr. Ian Mitchell.
Yeah.
Yeah, I think Penticton is also looking at that, Dr. Michelle Schiepers, Vernon. So it's something one could do in Vernon, as well. I just think it's a capacity issue in the hospitals. The ERs often have like 30 admitted patients, and it's just capacity. So that's unfortunate.
Particularly in Kelowna. I mean, we're at 127% capacity every day. So I know for sure that here, there's just not even physical space to be able to do this.
Even the IMOs, if somebody spends 3 hours in your clinic, if you have a social worker, connect them with IMOs, and if they're reasonably safe, that certainly makes them safer for a week or two. Seems.
Sounds good to me.
Sounds
Sounds great.
Yeah.
Preaching to the choir.
Yes, please, in the back.
I was wondering if you have an age criteria for referral.
Oh.
We do currently above the age of legal age of 19, but there's no limitation at the other end of the spectrum.
Great question. Anybody else? Yes, please.
How frequently do you bring people back for more treatment?
So currently we do 3 intramuscular treatments in a 4-week period, and then that's also combined with their psychotherapy, their mindful movement, et cetera. They complete a 4-week treatment program. Because we're a relatively new clinic, we've just begun, so we've done this, we're on our 2nd cohort of patients currently, so we'll see as this goes along, if we have to bring patients back, we will have that option available to them to come back for either repeat ketamine administration with or without psychotherapy, so there will be those options available.
It seems to me that this is, for some people, it may be something that may be recurrent lifelong.
Correct, yeah, and that is what the evidence shows. I mean, the more infusions in the US that, according to the studies, the more IV infusions that were given, the better patients did. So there is the potential that they will need ongoing treatment and care, whether it's every month, every 6 months, every 8 months, 10 months, that's variable, so we don't know that number. And then I think that will be left up to, the patients and their psychotherapists or,
Individual.
yeah, individualized for sure.
If that worked out to be the case, over the years, would maybe the price for one individual become less? Because that's that for me, for a lot of my patients, the price is going to be the rate.
Correct, yeah. So there will be an alternate price, obviously, for just getting repeated administrations. The price we have currently is for the sort of whole program that they undergo for the 4 weeks.
What is that price?
It's $5,600.
And that includes a number of...
It includes 3 intramuscular ketamine sessions. It includes 4 individual psychotherapy sessions, 4 mindfulness and movement sessions or breathwork sessions, plus evaluation by psychiatrist and anesthesiologist.
Mm-hmm. Yeah, I just want to sort of give some context here. There's some clinics who do IV ketamine for CRPS, and they charge almost $3,000 for 1 infusion. So we're not. I think this program, to run a good program and a solid program, unfortunately costs money, but it's. I think it's if you look at the grand scheme of things, it's economical for most patients, as opposed to being off work for months and months. I mean, acute, severe depression is very costly to the individual and society. And we're actively working on getting some insurance coverage for this work, which is ultimately what we'd like to see.
Yeah.
And maybe some MSP coverage.
And I think when you look at comparatively to other programs that, everyone sort of does a version of this program, right? People are modeling, copying each other, et cetera, or making their own version of a program. I think the unique thing here is we're giving intramuscular ketamine, which has a way higher bioavailability. So lots of programs across the country are doing PO or sublingual ketamine and charging about the same amount of money with, a 16 to 20% bioavailability of the actual medicine.
Mm.
From what I understand, it hasn't been the subject of careful research yet, except for that one article I put up at the beginning by Doré and Wolfson. But there's, in the U.S., I think people are going, in some clinics where it's been more long-standing, there are folks who will go every 4 months for a session and from what I hear reported is sometimes it starts to reduce, so people will start off with a heavy dose and then maybe they come for a booster at 4 months and then maybe they're like that for a year or 2 and it can decrease. I think that knowing that it's out there for people who are struggling with depression and knowing that there is something that can alleviate it is huge. Even if they're relapsing, they do know that option is out there to do it again.
Just in comparison, I did a 2-month PTSD program inpatient. It was $40,000.
Whoa.
Paid for by the government, but a lot of money that they could be putting to probably better use for a program like this.
And hopefully we're just years away once we build the evidence that it will be something that's covered by MSP because the evidence is growing. We just don't have evidence for these long-term treatments yet, which I think will be the rule. I mean, people take antidepressants every day.
There is an insurance company that's just launched in the States that's dedicated to covering psychedelic-assisted therapy, and I assume in Canada it'll be similar as things develop. All right, any other questions? Yes, please.
I'll keep going.
Yeah, keep going. Make these guys work.
More for the researcher, the far left. I have a lot of patients who have Alzheimer's dementia. Dendritic dieback, we're talking about this. Is there any thought or future research in this respect? That's a huge impact on society. Is there anything maybe down the road that this might be some relief or some help?
Yeah, I mean, I can't speak to ketamine specifically about that, but I know with the classic psychedelics such as psilocybin, there's a lot of movement towards using them potentially as a treatment for Alzheimer's and also things like traumatic brain injury. So these are disorders where you need to, basically help the brain repair its nerve cells, help repair neurons. And what psychedelics do is they give your brain essentially more neuroplastic resources to do that and recover. And there's a lot of people anecdotally who say it really helped them get over their concussion or what have you. And there's companies in the whole industry that are focused on that. But as yet, there's no published research showing it in a clinical trial. I'm not sure if you know of anything with ketamine specifically for this. But
I just had someone call me the other day about that actually, and I had to say I don't know. I don't think there's anything on ketamine and Alzheimer's. But there's a lot of encouraging stuff about microdosing too for...
Yeah, so that's the other side of this. Yeah, there is evidence that microdosing, which is taking a very small of a dose of, let's say, mushrooms, say a tenth or less of the dose you'd usually take, does increase things like brain-derived neurotrophic factor. There is one study, I believe actually it was with LSD, that showed that. So there is potential that taking very small, like non-consciousness altering doses of certain of these compounds can induce neuroplasticity in a way that might help with things like this, with potentially Alzheimer's, dementia-like symptoms, and also traumatic brain injury. But still, a lot more research needs to be done, and ask again in 3 years, and probably some stuff will be out there.
We have a study in press, actually, it'll be out in a couple of months, showing in over 55-year-old people, the microdosing psilocybin was related to increased performance on the TAP test, which is a good marker for Parkinson's.
I've seen that.
No, you're not.
I know, I was just looking at my dad.
There's a baggie. Yeah, I think that'll be an interesting field of research. I think we could always look at that
Absolutely.
later.
All right. Yes, sir.
In the, like, for example, in the emergency department setting, when ketamine is used for like a conscious sedation, is there any benefit in regards to mood if it's used for a different indication?
Yeah, it's a good question because I used to do procedural sedations all the time, and I remember one lady coming in and she was actually quite depressed while I was still doing propofol sedations because she had sort of interstitial cystitis and she needed procedures done. As soon as I started using ketamine, this lady's depression actually lifted significantly, and over 3 years that I did that, we did that every 6 to 8 weeks. She was not depressed. So there's a few case studies like that. I'm not sure if there's enough data.
Well, there is some evidence to show that, lots of patients who had come to the eMERGE for incidental, having a fractured arm and getting a reduction in their fracture, who then received a single dose of ketamine. This is where some of the initial studies came from, actually showed that they had profound antidepressant effects. And so there is actually evidence for that, even with single doses.
Yeah.
There's been some research from PTSD when folks were brought in after an accident and treated with ketamine as an anesthetic, that their PTSD, it helped their PTSD
was less.
result.
We're good? All right. Well, on behalf of EntheoTech and the entire panel, thank you for being here tonight. Please give them a warm applause.